Hello everyone. So today we are going to continue our discussion on preeclampsia, and we will be talking about investigation and management of preeclampsia in this video. So talking about investigation, first of all we have to do the urine test. That is, proteinuria is the last feature of preeclampsia to appear, and there it may be trace or at times copious, so that the urine becomes solid on boiling. We have to do the urine protein test and all those dipstick, and we have already discussed about this in previous video. And nextly we have the ophthalmologic examination, and in severe cases there may be retinal edema, constriction of arterioles, alteration of normal ratio of vein arterial diameter from 3:2 to 3:1, and nicking of vein when crossed by arteriole, and there may be hemorrhage. So we'll be talking about this ophthalmological feature in the hypertension in detail when we will come up with the ophthalmology video. And till then, just remember that we have to do the ophthalmological examination. And the grading of retinal changes, we can do the following grading of the retinal changes. The grade 1 is means the normal fundus. The grade 1 to 2 means arteriovenous narrowing or angiospasm. Grade 3, the presence of edema or hemorrhage, the presence of edema and hemorrhage or exudate. The retinopathy of pre-eclampsia, and G4 means grade 4 means papillary edema. And we have the blood values. We have to do the different blood tests like serum transaminase, AST, ALT, LDH concentration are more than or 2 times upper limit of their normal range, and there may be thrombocytopenia as defined, which is defined as platelets less than 1 lakh per microliter, and serum creatinine is more than or equal to 1.1 milligram per deciliter, or there may be doubling of serum creatinine concentration, and the serum uric acid is more than or equal to 4.5 milligram per deciliter, and there may be abnormal coagulation profile. And the coagulation profile is not necessary when platelet count and liver enzyme are normal. And the antenatal fetal monitoring, antenatal fetal well-being assessment is done by clinical examination, daily fetal count, ultrasonography for fetal growth, and the Lycor pocket, and the cardiotocography, umbilical artery flow velocimetry, and the biophysical profile. We have discussed about complication in previous video. Talking about management, so what are the prophylactic measures we can do for preventing the preeclampsia? So firstly, for primary prevention, we have to take care of the various risk factor, as we have discussed in the previous video. What are the risk factor? We have to take care of the risk factor like the primary gravida, young or elderly, first time exposure to chorionic villi, risk factor. So we'll be shortly revising about the risk factor. Okay, risk factor of preeclampsia is one of the primary gravida, young or elderly first time exposure to chorionic villi, the family history of hypertension, preeclampsia, gestational diabetes mellitus or diabetes mellitus, and the placental abnormalities like hyperplacentosis, excessive exposure to chorionic villi, like in molar pregnancy, multiple pregnancy, diabetes, and the placental ischemia, and the inter-pregnancy interval. If there is more than 7, then that can be risk factor. And obesity, if the BMI is greater than 35 kilogram per meter square, or insulin resistant, history of PCOS, these all lead to preeclampsia. And pre-existing vascular disease, new paternity, pregnancy following AR assisted reproductive technology, IVF, thrombophilias like Apla syndrome, P protein CS deficiency, factor 5 lead-in mutation. So for all this we can do the primary prevention like maintenance of the preventing obesity, and preventing obesity, and all those things. The inter-pregnancy intervals should not be more than 7, and all those things. And the next we have the regular antenatal checkup for early detection of rapid gain in weight. Regular antenatal checkup should be there, and there should be exercises like physical activity, stretching exercise should be done. And we have the exercise, and we have the antiplatelet agent, the secondary, the low dose aspirin, 75 to 150 milligram daily beginning early in the pregnancy in potentially high risk patient. This antiplatelet agent, low dose aspirin, this selectively reduces the platelet thromboxane production. Aspirin in low doses is known to inhibit the cyclooxygenase in patient, thereby preventing the formation of thromboxane A2 without interfering with prostacyclin generation. And the heparin, or low molecular weight heparin, is useful in women with thrombophilia and with high risk pregnancy, and it is not recommended as routine. And the calcium supplementation, 2 gram per day reduces the risk of gestational hypertension. The antioxidant like vitamin C, E, and the nutritional supplement along with magnesium, zinc, fish oil, and the low salt diet have been tried but are of limited benefit. And the balanced diet rich in protein may reduce the risk, and sildenafil is of some limited value. So one of the important thing we have to do is antiplatelet agent, heparin, calcium supplement, and these are useful thing. So there, this table shows the indication of aspirin therapy in pregnancy. The high risk factor in the high risk factor, one or more of those factor: preeclampsia and previous pregnancy, chronic kidney disease, autoimmune disorder like SLE, Abla syndrome, type 1 or type 2 diabetes, chronic hypertension. And the moderate risk factor means the abnormal placentation, age more than 40 years, pregnancy interval greater than 10 years, BMI greater than 35 kilogram per meter square, family history of preeclampsia, and the multifetal pregnancy. If there are 2 or more than 2 this factor, then we have to give the aspirin therapy 75 to 150 milligram in pregnancy. So talking now, we'll move on to management of gestational hypertension and preeclampsia. Both of these management are same. As long as the etiology of preeclampsia remains obscure, the treatment is mostly empirical and the symptomatic. And the objective of treatment are to stabilize hypertension and to prevent its progression, to prevent eclampsia, HELP syndrome or eclampsia, to prevent complication, to prevent eclampsia, to deliver the healthy baby in optimal time, to restore the health of mother in postpartum period. And the home or hospital treatment, ideally all women without severe feature can be managed as outpatient and should be monitored in hospital or in daycare center. The daily fetal kick chart, ultrasonography for fetal growth at every 3 weeks, daily maternal BP monitoring, weekly CBC, liver enzyme, serum creatinine, evaluation of maternal signs and symptoms are to be done, and any evidence of disease progression need urgent hospitalization. The preeclampsia with severe features mandates hospitalization until delivery. The initial management is same as that of preeclampsia without severe feature. The blood pressure is stabilized with antihypertensive drug to maintain BP less than 160 by 110 mmHg, and the fetal monitoring is also be done. Daily NST with twice weekly BPP should be obtained, and ultrasonography for fetal growth including Doppler study for umbilical artery at 2 weeks are to be done. And it is essentially that she should be warned against ominous symptoms like headache, visual disturbance, vomiting, epigastric pain, and scanty urine. The hospital management are the admission in hospital, and the rest is helpful for continued evaluation and treatment of the patient. While in bed, patient should be in the left lateral position as much as possible to lessen the effect of Benecabal compression. The rest increases the renal blood flow and it helps in diuresis, and it increases uterine blood flow, improves placental perfusion, and the rest also reduces the blood pressure. However, the complete bed rest is not essential. After rest, we have the diet. The diet should contain adequate amount of daily protein, about 100 gram protein, and low salt intake is permitted. Food need not be restricted. And the diuretics should not be injurious as they can harm to the baby by diminishing placental perfusion and by electrolyte imbalance. The compelling reason for its use are like if there is cardiac failure, then we can use it. If there is pulmonary edema, or along with selective hypertensive drug therapy, diazoxide group, where blood pressure reduction is associated with fluid retention. If there is massive edema not relieved by rest and producing discomfort to the patient. And the most potent diuretic commonly used furosemide, 40 mg given orally after breakfast for 5 days in a week. In acute condition, the intravenous route is preferred. And the antihypertensive drugs have limited value in controlling blood pressure due to preeclampsia. The indication are persistent rise in blood pressure, especially when the diastolic blood pressure is over 105 mmHg. The use is more urgent if it is associated with proteinuria. In severe preeclampsia, to bring down the blood pressure during pregnancy and labor, the common oral drug have been used, like the labetalol, nifedipine, hydralazine, and we will discuss this now. These are the commonly used drug management of preeclampsia. In labetalol, it is adrenoreceptor antagonist, that is alpha and beta blocker, both alpha plus beta blocker, and it is dose is used with 100 mg 3 times daily or 4 times daily, and it is to be avoided in case of asthma, heart block, bradycardia, and the myocardial disease. These are contraindication of the beta blocker. And the nifedipine, it is a calcium channel blocker. It is used 10 to 20 milligram 2 times daily, and it causes tachycardia and headache. And we have the hydralazine, this is smooth muscle relaxant, and the hydralazine causes again hypotension, hydralazine headache, abdominal fetal dressing, and that's or table 10.3 means this. What does hydralazine do? So it is maternal hypotension, headache, and an abnormal fetal artery tracing. These are the used drug in severe hypertension. Again, labetalol, hydralazine, nifedipine, these are same. And next is we have nitroglycerin sodium, and we have the nitroprusside. The onset of action 5 minutes, and the very short acting. And the dose schedule is these drugs are used IV in the management of severe hypertension. 10 to 20 mg IV every 10 minutes, and maximum dose. This is maximum dose maintenance, and it is avoided in asthma, myocardial disease, heart block, bradycardia, as we have already said. Labetalol, hydralazine, again it is used IV, and the maternal hypotension, headache, abdominal fetal dressing. And nifedipine, 10 mg, it can be, so nifedipine is used oral, and these were IV, but it is oral, and the reflex tachycardia and headache. And we have the nitroglycerin sodium nitroprusside. This is again certain the flushing, hypovolemia, and cyanotoxicity. So these are the drugs that is used when the hypertension is severe, that is more than 160 per 110. And we have to maintain the progress chart also. The effect of treatment should be evaluated by maintaining a chart which record the following, like a daily clinical evaluation of any symptom like headache, right upper quadrant, epigastric pain, visual disturbance, oliguria, the blood pressure 4 times a day with appropriate cough size, state of edema, and daily weight record, fluid intake and urinary output, the urine examination for protein daily, and if it is present, then to estimate its amount in 24 hours urine, blood for hematocrit, platelet count, uric acid, creatinine, and liver enzyme like AST, ALT, LDH, coagulation profile at least once a week, ophthalmologic examination on admission to be repeated if necessary, and fetal well-being assessment like fetal growth profile, BPD, biparatal diameter, head circumference, abdominal circumference, all those things are to be done. And the duration of treatment is the definitive treatment of preeclampsia or gestational hypertension or eclampsia is delivery, the termination pregnancy. So that's why the treatment should be until the delivery takes place. And the duration of treatment usually depend on severity of hypertension, duration of pregnancy, response for treatment, and maternal and fetal evaluation report. Okay, this table shows the scheme of management of preeclampsia. So this is preeclampsia, that there is a clinical assessment, outpatient, daycare, or admission. At the admission, first tab we have the rest, BP checking 6 or more times a day. Rest we have already discussed why we should give the rest, and the complete blood count, platelet count, coagulation profile, and uric acid, creatinine, LFT, urine for protein, these are to be done. Ophthalmoscopy is to be done, and the fetal well-being assessment, daily fetal movement count, non-stress test, cardiac tachography, physical profile, ultrasonography, and all these are need to be done. And we have the anti-hypertensive therapy like labetalol IV, hydralazine IV, or nifedipine orally should be given. Nifedipine is oral, but these two are IV, as we have already discussed. And the hypertensive therapy are to be given in the abnormal report if this if the BP is controlled and there is no severe feature, then we have to there can be if there is preterm, the woman is preterm less than 34 weeks, then we have to discharge to attend the anti-clinic or day clinic until 37 week, and finally we have to do delivery. And if there is term pregnancy close to 37 week or at least greater than 34 week, to stay in hospital the pregnancy for more than or 37 week and the delivery. And the pre-eclampsia severe feature, if pregnancy is less than 34 weeks, we have to do admission and monitoring. And the maternal fetal condition is stable, no percent symptom, try to continue at least 40 weeks, and we have to do delivery. And the preeclampsia is severe feature and indication for immediate delivery. Delivery irrespective of duration of gestation. We have to do couple counseling, transfer to tertiary care with neonatal care unit, prophylactic magnesium sulfate therapy, steroid therapy if pregnancy is less than 30 weeks, and antihypertensive therapy. And we have to do the delivery. And the delivery we can do by induction of labor or by cesarean section. The method of for induction of labor is, if the cervix is ripe, the surgical induction of by low rupture of membrane is the method of choice. Oxytocin infusion can be added. If the cervix is unripe, the prostaglandin E2 gel 500 microgram intracervical or 1 to 2 milligram in the posterior pharynx is inserted to make the cervix ripe. And when low rupture of membrane are performed, severe eclampsia antihypertensive should be used during induction. And cesarean section, the indication are the when if there is urgent termination is indicated or and the cervix is unfavorable. And unripe cervix, if there is severe preeclampsia and if there is very much the complicating factor, then we have to do the cesarean section. After we do the delivery, we have to do the postpartum monitoring, and this is the management. And as we have already discussed, delivery, induction, cesarean section, and management during labor. The management during labor includes the control of hypertension, prevention of convulsion, and safe delivery. And the hypertensive drug is continued, and the BP and urine output is monitored every hour. And the prophylactic magnesium sulfate is started with severe feature of preeclampsia, and the careful monitoring of the fetal well-being is mandatory. So, and the postpartum management, we have the patient is to be watched closely for at least 48 hours, the period during which convulsion usually occur. Antihypertensive drugs should be continued if the BP is high, if the systolic BP is more than 150 mmHg or diastolic more than 100 mmHg. And oral nifedipine 10 mg at least 6 hours is given until BP remains below hypertensive level for at least 48 hours. Oral furosemide can be done, and magnesium sulfate for at least 24 hours, and antihypertensive drug to be continued in women with severe hypertension. And these patients are increased risk of preeclampsia, hypopulmonary edema, stroke, and the patient is to be kept in hospital till blood pressure is brought down to the safe level. And in breastfeeding women, labetalol, nifedipine, and enalapril may be used on discharge. And the methyl-dopa is avoided due to risk of postpartum depression. So that is all about preeclampsia. And in next video we will be talking about some other topic in obstetrics. Probably we will discuss about eclampsia. And thank you. Till then, keep revising and reading. Thank you.